There we go. So, welcome to the evening mentoring session, and we're going to talk about squamous and surface epithelial cell lesions today. And there are 9 digital slides that we have to work with. The link to these slides, if you want to study them later, is in the materials on the iEcho site, so you should be able to get access to them there. But we'll also post the link to these slides in the recording. So here's a nice lesion to begin with. And this is, as you can see, a surface epithelial proliferation. What do you notice here as you look at the maybe the boundary here between the more normal stuff at the edge and this material in the center? What jumps out to you at low magnification? V, do you have any thoughts? You had some great thoughts this morning.
And from this low power, I see the hyperkeratosis,
Very good.
hyperpapillomatosis, and
Papillomatosis, yes.
and the inflammation, lymphocytic infiltration in the superficial dermis.
Yeah, very good. So at low magnification, just to sort of think about how to examine a skin slide, I usually, like you just did, start at the surface and then work downward. So we see that the keratin layer is thickened. And even at this magnification, we can see that some of it is kind of this pinkish red, and some of it is a little bit more normal basket weave. So I'm thinking there's not very much of this that is going to be parakeratosis based on this. We also notice that these reedy papillae are fairly elongated. There is what we call acanthosis or thickening of the epidermal component, and it's fairly uniform. Note that each of these little reedy pegs extends down to about the same level. And there's a certain number of entities which tend to do that. It includes psoriasis and so forth. But in general, would you think that this type of proliferation, sort of even across the whole spectrum, is more likely to be benign or malignant?
I think that would be benign lesion.
Yeah. So although some cancers can, or in situ lesions can have a uniform extension like this, like vulvar neoplasias and so forth, but in squamous cancers or basal cancers, there's more irregularity to that. So there we are at low magnification. We've already pretty well said this is a squamous proliferation, and it's more likely to be benign, and it's hyperkeratotic and papillomatous. So let's take a look here first at the keratin and see if I was correct. So here we have sort of normal basket weave keratin. Here we have a little bit of parakeratosis. So I was wrong about that. There is a little bit of parakeratosis in some areas of the stratum corneum. Now, as we look at this epidermis, as we look at this squamous epithelium, um, we're looking to see, what's the degree of atypia or what else is going on here. And in high magnification, I think you'll agree that these are all fairly uniform cells. There's not a lot of pleomorphism. There's not macronucleoli or anything like that in any of these areas. We're not seeing really atypical mitotic figures. Now, what we do have is these sort of edematous areas or clustered areas like this where there's some edema. So we might wonder and think, well, maybe this is an inflammatory dermatosis. Maybe this is something like lichen simplex or something like that that has a lichenoid pattern or acanthotic pattern as we've described. But we also will be able to identify here, I think, a few areas where um, it looks like we have this sort of uh, nodularity to it, almost like nests of nevus cells, like here, um, and over here. These sort of are what is sometimes called a clonal growth pattern, little clusters of cells, and these are not particularly different than the surrounding cells. There is a little bit of edema and discohesion, but sometimes this lesion, here's another one of them here. This is a lesion that can sometimes mimic melanoma because of this sort of clonal pattern of growth. This may actually be a mitotic figure there. So we found one mitosis. Um, but most melanocytic lesions are not usually associated with this degree of acanthosis. There are some that can, some of the nevi will show that pattern. But taking these things together, hyperkeratosis and this sort of clonal, more squamous type of epithelium, it begins to fit into the pattern of what is called an irritated seborrheic keratosis with sort of clonal pattern growth. Um, this is perhaps as close as we come to a squamous pearl, or in these irritated seborrheic keratoses, a squamous eddy, which is sort of a whorl of keratinocytes that are growing together. And that's actually what these clonal areas are. Only in this particular one, these clonal areas, these squamous eddies have become very inflamed and edematous. As you can see here, there's a lot of um, space between the keratinocytes. And it almost looks what we call spongiotic, where you can see the spongiotic space between the keratinocytes and these spiky um, uh, tight junctions stretch to their limit in this lesion. So seborrheic keratoses are very common. And usually they have sort of nests of keratin material. Usually it's orthokeratotic, not usually parakeratotic. But when they get irritated or when they've been around for a while, they may develop this. When someone's been rubbing them, for example, they may develop some of these keratin pearls. Another feature of seborrheic keratosis is the very sort of flat bottom. It has a very uniform lower level to which it extends. The inflammation here is sort of a mark of the irritation and the clonal growth. It's not a marker of malignancy or of there being other inflammatory dermatoses, sort of things going on. So we wouldn't usually mistake this for one of the lichenoid dermatitises, but that would be in the differential for sure, because that usually seborrheic keratoses are not particularly inflamed. So there are some great examples of seborrheic keratosis in your study sets for the Derm module, but I thought this was a little bit of a variant that you might not see very often that would be good to review. Questions or comments about seborrheic keratosis? Dana, I bet this is a skin diagnosis you can still make, right? Well, she may still be driving, so we'll give her a pass on that. All right. Well, if no further questions, let's go on to the next slide. And you can see here again we have hyperkeratosis, but I'm going to turn it right side up here so that we can look at it more normally. At low magnification, we see this big mound of pink stuff. Does anybody know what this is called, sort of clinically when you see it in the exam room? What do we call these sorts of things? Have you heard the
Is it a
term?
papule?
That's a clinical term. You're right. A papule is a bump, but keratinized bumps uh, like this that sort of really stick up quite prominently above the surface are sometimes called cutaneous horns because they can grow quite long and they can be fairly localized in their base, so that it actually can develop very much like a horn, a small horn sticking out from the skin. Now, can we tell at low magnification what part of the body this is from? I know this is asking a lot, but um, the thickness of the epidermis may tell us something about the part of the body that it's from. It's not from the palms or the soles. So it's developing a cutaneous horn. It's not from the palms or the soles. And we see that it's hair-bearing skin. It's got some hair follicles here. And it also has a feature called solar elastosis. So that is this bluish, very faint bluish tinge to the superficial dermis. So we know that it's also sun-exposed skin. So this could be from the arm, it might be from the face, back, probably not back of neck or back because this epidermis there tends to be thicker than it is here. So I would say, probably someplace on the forearm, hand, or face would be the most likely location for this. And obviously someplace where you've got hair follicles. Now, as we look at this cutaneous horn, we see a couple of variations going through it. So it's not all like this, very uniform. We have these sort of I don't know, pancaked or lamellar-like areas, maybe some cystic areas going up through there. What are these?
The keratin pulse.
No, but that's a good guess. So what's beneath these here? Do you see what the continuity is down here or down here?
Maybe the duct of the eccrine coil.
Yes, yes. So these are adnexal sweat gland ducts or hair shafts, things like
Mm.
that. And the reason that they tend to be preserved like this is that they are not undergoing the same kind of damage that the adjacent tissues are. So right here, for example, you see epidermis and you see a nice granular layer, but on both sides of it, we see epidermis, but there's really very little in terms of granular layer. And so because these tend to have less of the inciting damage that causes this lesion, they tend to be preserved in their functionality and their maturation um, due to shading or due to some other factor. So the hair shafts oftentimes will be preserved in this process. So cutaneous horns are seen with abnormal squamous proliferation. They're derived from these squamous epithelial cells, and the maturation is altered. You have the loss of the granular layer. And so that altered maturation is, in this case, associated with what do you see as you look at this, squamous epithelium here? What's this and this? Maybe this. Mitotic figures. And as we look at these cells here, they look a little bit atypical. There's a little bit of pleomorphism to them, a little bit of variability in how they're connecting one with another. And then for contrast, this is a nice example because we have the more normal epithelium here to the side. So we can see there's a little bit of hyperplasia compared to this cutaneous layer over here, which is more normal and shows basal layer, intermediate layer, granular layer, keratinocytes, stratum corneum above that. So here's a normal for comparison at the side, and we can compare maybe the mild nuclear variability here with a little bit more pronounced nuclear variability over here. And we can see there's a fairly abrupt change right here where you have sudden abrupt loss of the granular layer as you come into this lesion. So putting all of these things together, sun-damaged skin, loss of granular layer and normal maturation, nuclear variability, a little bit of hyperplasia, mitotic figures, and so forth. What kind of a diagnosis are we thinking about with this process, do you think? Wynn, do you have an opinion?
Actinic keratosis.
Exactly. And of course, you can't tell that's the diagnosis when you're just looking clinically at this keratin horn. And so, this could be a situation where you have a more deeply invasive lesion associated with a cutaneous horn, or you just have, as in this case, sort of a dysplasia or actinic keratosis that has developed and is creating that horn. So I do need to tell you a little story about myself. When I first went into practice, and I was seeing a fair number of skin cases, we didn't have a dermatopathologist, and I was fresh out of training and so forth. We had one very active dermatologist, and he would do a lot of very superficial shave biopsies of these kinds of lesions where you had some actinic damage and so forth. And in many of them, we had nearly full thickness atypia. And I had been trained in an environment where, we would call full thickness atypia squamous cell carcinoma. And, he didn't say anything right off the bat, but after I'd been there about a year, he came to me and he showed me a graph of the incidence of squamous cell carcinoma in his practice, and it had gone up dramatically about the time I had joined the practice. And then he said to me, I share my reports with my patients, like is a very common practice now in the United States. They see their reports, and they get very nervous when they see the carcinoma word. So could you maybe tone it down a little bit and so forth? We know these aren't really dangerous carcinomas and so forth. So I began to use actinic keratosis with some modifications to convey that level of atypia a little bit differently. And sure enough, the incidence of squamous cancers in his practice dropped back down to a little bit more acceptable rate. And he was pleased that his patients weren't calling him back every time they saw their report and so forth to say, what was this about cancer? So obviously, actinic keratoses can be quite variable. So I pulled a couple of other slides to show as well. And here's another example. Obviously, this is a very thin shave biopsy. It does have a cutaneous horn, but it's not at all parakeratotic. It's purely orthokeratotic, stratum corneum. And as we look at the epidermis, look at what a remarkable job the dermatologist has done in just barely getting under the epidermis. This is the sort of lesion that will leave, this is a sort of excision that would leave virtually no scarring with the removal of it. But as we look here, I think you can see there's just a very subtle pleomorphism to the cells here. So not as dramatic as the previous case. We still have a little preservation of the granular layer and distinction between the cornified layer and that. And so I think this also it's a much more mild seborrheic keratosis, something that's a little bit less dramatic. Here we do have a little bit of papillomatosis to it, still preserved. And we don't see the underlying solar damage, but unquestionably this is another solar elastosis related stratum, excuse me, actinic keratosis. What we do see here is actually a different stain that is pulling out the elastotic changes in the papillary dermis that are related to that solar damage. And that highlights the fact that staining differences can vary quite significantly between laboratories. So in this laboratory, their hematoxylin was sufficiently intense that it was picking up the elastosis with a fairly nice bluish purple color, whereas in the previous one, it was just a very, very slight pale blue. So the recipe for staining can be variable. Pathologists' eyes are good at making that adjustment, and so forth. We have that ability to sort of see through it, if you will. But this is one of the areas that's a challenge sometimes when the people start to develop artificial intelligence algorithms and so forth to classify things based on coloration and intensity of staining and so forth. Standardization of staining becomes a bigger problem for the laboratory. Okay, one more example of our actinic keratosis. Again, one with a bit of a cutaneous horn. And again, you see the areas of preservation of some of the underlying adnexal structures. This one has some variability in terms of the granular layer, but it seems to be mostly lost, and we're getting into parakeratosis. And here again, we're seeing a bit more of the squamous atypia. Notice some very large cells in the basal area, some more macronucleoli, and variable degrees of spongiotic change. And you can even get at times this sort of clefting, that spongiosis can become sufficiently significant that you get a little bit of a cleft along with it. And again, some inflammatory changes that go along with that. And that probably is a sort of tumor immune response to some degree, because these squamous cells will have some alteration of their antigenic structure. Now, what happens with some of these squamous cells, and you're beginning to, or the actinics, is what you're beginning to see here is what I would term an actinic keratosis with some basilar proliferation. So this type of downward budding of the basal epithelium is what was leading me to call these superficial squamous cell carcinomas. But whether you use that term or a term like actinic keratosis with basal proliferation, or hypertrophic actinic keratosis with basal proliferation, or something like that, this is a significant thing to communicate, because it does say that this was kind of a little bit further along in terms of its development and potential invasiveness coming to pass. Obviously, because it's on the skin, usually clinical examination, the patient's own self-examination and so forth will pick these up. But you like to sort of have the patient be examined frequently enough that they're not going to have enough interval time to really develop a more damaging and invasive characteristic. So recognizing that you've come to this level of sort of early basal proliferation, that may be a tool to adjust your examination interval or something like that to detect these lesions before they become more disfiguring, before they become more potentially invasive. So does anybody have any questions or thoughts about actinic keratosis that you want to bring up?
No, it's not really directly related to the histology, but I'm just curious whether like general pathologists, let's say the community pathologists, still give these diagnoses for skin conditions, because now I know that the more and more dermatologists are taking over the DAMPAT portions, even the fellowship training. So I want to know what the role of the general pathologist here.
So yeah, every community is a little bit different. And just in terms of the sort of the pathways to certification in the United States, there is a dual pathway to becoming board certified in dermatopathology. One follows a clinical route with significant pathology experience. The other follows a pathology route with significant clinical experience, because it's important for the dermatopathologist to have a fair bit of understanding of both sides of that equation. Um, the real issue sometimes becomes when the dermatologist is using a technique such as dermoscopy, which is essentially a form of in vivo microscopy, using some form of light illumination directly on the surface to evaluate for certain kinds of features such as vascularity, cellularity, thickness, and so forth. That may give them a guide in terms of whether or not they can just freeze the lesion, just use cryo obliteration, or whether it's a lesion that needs to be excised and submitted for histologic examination. There are a lot of cutaneous lesions like verruca and so forth that are not submitted for evaluation. There's probably many seborrheic keratoses also probably can be cryosurgery removed and distorted and not submitted for evaluation. And in the hands of a capable dermatologist with some good education, that's probably a fairly safe thing to do. The difficulty is when you start to get into pigmented lesions. I'm sure Dana has probably seen cases, as I have, where a patient shows up years later with a metastatic melanoma, and you find the history is there's no history of a cutaneous lesion. Oh, yeah, well, I had that skin tag removed a couple of years ago, and he didn't send it for evaluation. So skin tags can notoriously harbor melanocytic lesions and probably should not just generally be frozen off. But it does take experience and good judgment to do that. In some community settings where there's no dermatopathologist nearby, the general pathologist may handle the lesions, or many family practice or general practitioner doctors will remove these kinds of lesions and submit them to pathology and their local pathologists. So a good understanding of the common lesions in dermatopathology, I think, is important for every pathologist, and also for every clinician to understand kind of the kinds of diseases that they might be dealing with and the sort of excision or management of those lesions clinically, whether to excise, whether to do a punch biopsy, or whether to refer to for surgical, full excision is important. I think very, very often you have different levels of skill in terms of the excision as well. So you've seen, the varying depth of excision. This one is still mostly in the papillary dermis, so there probably wouldn't be too much scarring. And some dermatologists are extremely adept at doing these superficial shave biopsies. Most general surgeons and other doctors in the surgical field, they're more into sort of vertical incisions rather than horizontal shave excisions. And so if it's a lesion where there's some depth to it, then a general surgeon can handle it. But a superficial excision, very superficial lesion like this, many superficial basal cells, I think probably do better if they're evaluated by a dermatologist who's adept at that horizontal shave excision. What's your experience, Dana, in your practice situation down in Florida? Lots of dermatopathology down there.
Well, there is, but I have shared with you my allergy for derm path. And so I have only chosen jobs where the derm path goes to the dermatopathologist. So I don't see much derm path in my practice, but I'm a little bit lucky because I get to pick and choose what I want to see. Not every
Yeah.
job is like
So the other area where you often will see a lot of skin pathology is in head and neck surgery. Those craniofacial surgeons and so forth will do a lot of the superficial plastic surgery in those locations. They're much more adept at the specialized topography of the ear, the eyelid, the nose, and so forth. And so those type of areas tend to go to the head and neck surgeons for evaluation.
So for like, let's say for the exam purpose, if you see a case which is you suspect whether it's a melanoma case, would you refer the patient to the general surgeon or the dermatologist?
Well, I think in that situation, I mean, if you're suspicious that it's a melanocytic lesion, that's going to need a primary good excision, I would say usually those will go to the plastic surgeon or general surgeon who has more tools. That is sort of a size-based thing. If it's just a mole that's a few millimeters in size, then that's certainly very comfortable having a dermatologist do that excision. But if you start talking to more than a centimeter in size, where you're going to maybe have a little bit more complicated primary closure, or even the possibility of a skin graft or something like that, you definitely want to be thinking more towards a plastic surgeon or a good general surgeon. And then, of course, if it does turn out to be melanomas, then, the clinical management beyond that in terms of sentinel node evaluation, molecular evaluation, and potential, immuno or other therapy for those patients becomes much more complicated as well. And the patients generally do better if they have even a sort of specific melanoma team who's equipped to take care of them and manage all the issues that are associated with that disease. We're certainly much better at treating melanomas now than we were 25, 30 years ago. And part of that's because we have more tools, we understand them better, but also we've become more specialized in terms of the management and focus the knowledge that's required to properly manage them into a selected group of specialists. So,
Thank you. Yep.
yeah, in my experience, those kind of things if it's a significant melanoma, it needs to go to a good oncologist who has experience with that management. All right, so let's take another little variation on this. So I mentioned that the head and neck surgeons have some degree of experience with this, and maybe the dentists as well, because this was a lesion that was right on the lip, right on the lip border between sort of the vermilion border between the skin on one side and the oral mucosa on the other side. So as we look at this case, I think you can see there's not much of a cornified layer. There's not a horny layer here or anything like that. But we do see a fair bit of inflammation, and I think you can probably begin to make out that we have a degree of a cell enlargement. Here's maybe a little bit of that basal proliferation, some variability in the size and shape of these downward projections. And then we have the inflammatory response. Here's our solar damage, our solar elastosis. And then we're getting a little bit of parakeratosis almost here on this, what should be an otherwise benign squamous border. So one area where you can also get this kind of solar damage is right in the lower lip, especially, which tends to get a fair degree of sun exposure. And in this case, it's termed actinic cheilitis. So it's not really it doesn't sound like a preneoplastic term per se, but nevertheless it is. I mean, it sounds like an inflammatory term, cheilitis, but because of the proliferation that you see here, some nuclear variability, enlargement, maybe even, I don't know, here you've got a little downward budding into this lesion. So these type of lesions also need to be, carefully looked at. And usually because of the inflammation and the vascular ectasia here, these lesions would tend to be a little bit different in color from the surrounding skin. So they would tend to be a little bit irritated and maybe a little bit red. And that's in an oral mucosa or near oral mucosa setting, that's a real red flag, if you will, or a marker to pay attention and maybe get that biopsy to make sure that they don't develop an invasive cancer in this site. Of course, if they use a pipe or cigars, that also accentuates the risk of squamous cancer developing in this site, because the combination of the solar damage and the nicotinic damage to this area can be compounded and truly additive, if not multiplicative, in terms of potential damage. Here you can see how deep sometimes this actinic damage goes. Here we're probably a millimeter or more from the surface. I don't have a measuring tool on this slide, but if you were to go from here down to here, whoops, down to here, you're probably well over a millimeter in terms of depth. So probably this patient had some pretty significant sun exposure for whatever reason. Okay, so let's leave. Any questions on actinic cheilitis before we leave that? So that's sort of the border zone between skin pathology, oral pathology, general pathology, dermatologist, head and neck surgeon, dentist, sort of thing. So any of those possible venues into the care system could be possible for a case like that. All right. Well, here we're going to move on to another area that is fairly common disorder in skin pathology. And this is not maybe the best slide, because as we look here, we can see, well, actually, let's start at low power. So where are we on the body? We've got hair follicles. We've got, fairly thickened epidermis. It's not that real thin sort of thing. So either it's a younger person or maybe a site like the back. And then as we look at the depth of the dermis, we've got a papillary dermis up here, not much solar damage. And then we've got a dermis that's thicker than our biopsy. Here we're down several millimeters. So this is most likely going to be someplace on the back or trunk, where you're going to have a thicker, more durable dermis. Now we can look at this and we can see there is maybe a little bit of solar damage here. You can see just a little bit of these blue elastotic fibers here, and this is more characteristic of the kind of solar damage you get on the trunk. It doesn't tend to be that homogenized kind of stuff that we saw that you would see on the hands or the face. Here, these elastic fibers will jump out as being more fibrous to it. So, you could look at this and say, okay, we've got a case of solar elastosis here. Maybe we've got a little bit of squamous hyperplasia. I don't see anything else really too concerning here. They've got a few melanocytes along the basal layer, but they don't look particularly abnormal. Stratum corneum is a nice kind of thin basket weave pattern. There's no parakeratosis here. Well, maybe there's a teeny bit right there, but nothing that we can really point our fingers at and say, "Oh, this is bad news." We do have some vascular ectasia. You see these little venules here that are slightly more prominent, and that can either be due to the solar damage or perhaps to something else going on nearby. So the thing that makes this case, I think, instructive is, well, here we can see one of the sweat glands, and probably this piece probably attaches somewhere down deep to this one. This piece, we can't really tell how it's oriented other than we have ink that probably marks the deep portion. And then we have this stuff that sort of got cut off on the slide. And so let's look at this and see, what does this look like? Does this resemble any normal structure that you can think of? So it may look a little bit like some of the hair follicle structures. They tend to have sort of this peripheral palisade and a little bit of central pallor. But we have an artifact here where we're separating the epithelial component from the surrounding stroma, which is one of the markers for basal cell carcinoma. We don't see it as much over here, but these very small nests deep in the dermis is one of the phenotypes of basal cell carcinoma. Now, it could be other types of sort of adnexal or basal proliferation, because as we look here, we see there's some clearing. And V, you commented this morning on the cases with clearing, what the differential is there. So this could be a little bit of sebaceous differentiation that we're seeing in this proliferation. We know that the hair shaft has sebaceous apparatus associated with it as well. But seeing this at the edge of the biopsy should make us concerned that there may be something deeper on. And one of the variants of basal cell carcinoma is a very insidious one that tends to have smaller nests that involve the dermis quite deeply and can be difficult to define kind of where their margin is or edge is. And so here's one where we could say, well, this is at the margin, the deep margin, and so this is going to need to be re-excised. I have another example of this entity here in this slide, and this is maybe more characteristic of the particular phenotype that I'm thinking of. Here we can see at low magnification how the surface is quite normal appearing. A little bit of stratum corneum. We don't see anything particularly coming off of the surface, but then we have this sort of bluish hue and small little cords of cells in the dermis here, extending quite deeply. And then here, a little bit deeper down, you've got a little bit more cohesive cluster, similar to what we saw in that previous slide, where you've got a little bit of central larger cells and the peripheral palisaded cells that are a little bit smaller and more atypical. So does anybody know right off the top of their head what particular variant of or what we should consider in the differential for this type of a lesion?
I think that would be sclerosing or morphiform BCC.
Yes, that would be certainly the first diagnosis you should think of. And that is an uncommon variant of basal cell carcinoma, but it's one that can be very significant because of its very ill-defined margin. See how it's sort of trickling off over here. Its deep extent. and so forth. And this is one of the lesions. If this presents on the face or something like that, or in a sensitive area, this is when they would be very, very inclined to use Mohs surgery to make sure that they didn't have any of this sort of reactive tissue or these potentially neoplastic nests in their final margins, because you don't want to leave this behind because it can come back with a vengeance. Other things that you might think about in this situation would be metastatic carcinomas. So patients who have breast cancer, for example, can also have a morpheaform, sort of cord-like pattern of metastatic disease that can look almost exactly like this. And so if you have a woman who has a history of breast cancer, you do want to make sure that that's one of the things you consider. Anything else you can think that might have this kind of an appearance or need to be considered?
I'm thinking
Seringoma.
of the desmoplastic melanoma.
Is that what you're going to say too, Win?
No, I'm saying seringoma, but this is like very deep. So
Yeah. Okay. So syringoma, a benign adnexal tumor, can have very small clusters of cells like this as well. And as V said, a sclerosing or desmoplastic melanoma. And that is very, very commonly has more spindly cells and so forth, and looks a lot like a scar. But then when you start looking down deep at the nerves like this, you see the cells, growing along the perineurium and so forth, and it is a one of those melanomas that we talk about, which are oftentimes not positive for conventional melanoma markers, the HMB45s or the MART1s, but will be positive with SOX10 and S100 usually. This lesion would not be positive with S100, but would it stain positively with pancytokeratins and some of the other markers that can be used for basal cell carcinoma. I didn't grow up in an era where you used immunoperoxidase or immunohistochemistry for basal cell, so I don't even know what all the markers are supposed to be anymore. But I know that there are some that can be useful in select situations if you're trying to differentiate this from, say, a skin adnexal tumor like adenoid cystic carcinoma or something like that. You might do a CD1117 for adenoid cystic and something else for morpheaform basal cell carcinoma. So that's my allergy to DermPath, is that I'm not very adept at it with in terms of immunohistochemistry. So, but these are sort of bread and butter lesions that we should be familiar with. So here's another variant, maybe a more common variant of basal cell carcinoma that illustrates some of the other spectrum of disease that we can see with this. This would be more what's termed the nodular variant of basal cell carcinoma, where you can pretty well tell where it starts and where it stops by the nodule or the large papule that it's forming. And you can tell that it's basal cell even at this magnification, because look at these big giant retraction clefts you've got between the epithelium and the surrounding stroma. I mean, if that isn't the classic hallmark of a basal cell carcinoma retraction, I don't know what is. The other thing that's very nicely demonstrated here is the degree of peripheral palisading that you get where the nuclei at the periphery of these nests tend to line up parallel to one another, perpendicular to the surrounding stroma. So those are all very nice features that say, I am a basal cell carcinoma. There are some other features here, maybe a little bit less commonly seen. So for example, necrosis is relatively less frequently seen with basal cell carcinoma, not impossible, but we have several nice areas of necrosis that can be seen. Sometimes it can be so eosinophilic that you sometimes wonder if these cells are keratinizing. So you might see, cells like this and wonder if this is a keratinizing lesion, because squamous cell carcinoma is much more typical to produce keratinization and cystic formation secondary to that keratinization. So if your biopsy were just of an area like this, where the cells are maybe a little bit more spindly, there's some obscuring of the border here, you might have difficulty if you were just looking at this one high power field here to call it a basal cell carcinoma without more evidence or more awareness of the cleft, for example. And that's actually a good game to play with yourself from time to time as you're studying cases, is to go to a high magnification field and say, hey, if I just had this on my slide or on the edge of the tissue, would I be able to call it a basal cell carcinoma or a squamous carcinoma or whatever it is? We used to play that game as trainees and show each other one high power field and see who could get the diagnosis correct. It's a good way to train your eye to be thinking about things, but you can also, one low power field, it can be also just as challenging sometimes to look at something and say, okay, what do I see at low magnification? And probably low magnification challenges are more valuable to you long term than the one high power field would be, because you're not going to start out just looking at one high power field. You're going to always start from this low magnification field. And that is a significant thing because your eye takes in so much information as you're looking at this. And it's processing that so much more quickly than anything else. You're comparing it with all the other things that and so forth. And very often that will produce that first knee-jerk type of reaction of, I know what this is. This is a nodular basal cell or this, whatever. And that impression, I would say, is correct probably 90+% of the time. Because, commonly we see common things, and that image that we have of common things is going to be very helpful. What you do after that is also important, and that is that you have to look for other features that verify that this is what you're thinking it is. So you look for the peripheral palisading. You look for the maybe occasional other vacuolated cells. Okay, could these be sebaceous differentiation in this, or could there be something else going on here? Things that might dissuade you from making that diagnosis, to sort of rule out, rule in things that are in your consideration. Dana, any thoughts on that process? Is that kind of how it works for you?
Yeah, I totally agree. And I just thought of a scenario where I don't know if anybody could avoid derm path in a hospital setting, and that's frozen, because they love to send these for frozen margins. I don't know if that's your experience, but yeah.
Yeah, if they've got a lesion that's big enough to need a to require a regional or general anesthetic, an OR space, then very often they're going to want to make sure that they've got clean margins. So you're going to have to be aware of what these things are and how they look on frozen section as well.
Yeah.
All right. Well, let's see if we can get one or two more lesions. Here's another variation on basal cell carcinoma. And now I'm telling you the diagnosis in advance here because I want you to look at this and tell me what's different about this lesion. What are you seeing here that might make you concerned or worried about something else? Yang, do you see anything there?
They are a little bit disorganized, but I cannot tell what it is. And yeah, more like hyperkeratosis.
I could give you controls and you could point to what you're seeing here. Let me do that. Uh, where do I do that? Let's see. Okay, I've given you keyboard controls, so you can kind of move to the area and maybe use your mouse or whatever to point at what you think is the abnormality.
Probably
So
this area.
yeah, so what is it in that area that's different from what we've seen before?
Looks more like dark and hyper
Yeah, there's dark stuff there, right?
right.
Yeah, okay. So who can help Yang out to know what that is?
It's a melanin pigment, and some are like melanophages.
Yeah, exactly. So
Thank you.
this is a pigmented lesion. Clinically, it looked black. It had lots of dark pigment in it. So I'm going to take the control back here.
How can I give it back to you?
Just leave your mouse alone, and it will let me move my. Um, okay, there we go. Okay. So clinically, this was pigmented and sort of nodular, and so there was some concern that this could be a melanoma. So that, from a clinical standpoint, comes into play here. And then, when you look at this lesion, it's got a bit of a spindle cell pattern and some sort of mucoid or myxoid stuff in between. And so some melanomas can have this kind of myxoid appearance, they can be spindle celled pattern and so forth. So that actually does become a consideration that this is a spindle cell nodular melanoma. And even to sort of go along with that, here's a couple of funky looking melanocytes in the epidermis. You don't really see a true in situ lesion here, but you do see some prominence to these melanocytes. But as Wynn noted, most of the melanin is in melanophages or in macrophage type cells. It's not in the tumor cells. And that's somewhat helpful. It's not an absolute criteria. So I think in this situation, if you're thinking of the possibility of a pigmented lesion, you definitely would want to rule out that these cells were positive for any melanocytic markers. Now, what do you do in the situation where you've already got brown pigment here in your stain? How do you avoid misinterpreting these cells as being positive for your immunoperoxidase stain on your slide?
So we would use the red chromogen.
Exactly. Yeah. So there are alternate chromogens that can be used with the same antibody that can be more readily distinguished from the brown pigment to avoid a false positive interpretation. So you want to be aware of that and alert your laboratory to the need to use the red chromogen rather than the brown chromogen for your assay. There is one other thing that can occasionally be done in some of these circumstances if you don't have access to that red chromogen for whatever reason. There is what's called a melanin bleach procedure where you can take the block and sort of immerse it submerge it for a period of time in a bleaching solution that will sort of pull out the melanin pigment and allow you to then restain the tissue with the standard reagents. The problem with that is that sometimes that procedure can also damage your antigenic structures and interfere with the the proper antibody antigen interactions that you need to make your interpretation. Okay, well, hey, we've gone through a full hour and I've exhausted all of my slides, and it's been great to be with you. You've had some great interpretation on these things. I appreciate your time and hope that it's been worthwhile for you. And any final questions anybody has? Any problems with the Derm module so far?
It's not a problem, but I found out that the progress it's obviously slower than other modules because it's quite
Yeah,
difficult.
so I was going to say something about that, especially as you get into the inflammatory dermatoses, that last week of the module. There are a lot of redundant materials in there. So this similar topic from several different lecturers' perspective, and they're not short lectures. So my recommendation to you in that regard is uh, to pick one of them and study that lecture well and study the slides well, but you don't have to listen to all of the lectures, go over the same thing 3 times, unless it takes you that long to learn it. I mean, there's no doubt that repetition is valuable for learning, but if you're studying things very, very carefully and you're looking at the slides, it's really looking at the slides is the most important part of the activity. It's not listening to, Dr. Cockerell or Dr. Singh or one of the other experts talk about the process itself. So maybe pick the one you like the best, whose voice you understand the easiest or whatever, or alternate from one part to another. But try to focus on the slides because that's really where the learning occurs in my experience. And we may end up editing that module a little bit to make it more concise because I am concerned that you could easily become bogged down in that. All right. Well, again, thank you so much for joining us. Any last questions or whatever, or things come up later, don't hesitate to reach out. We really appreciate the feedback on how things are going for you and want to help you be successful in this process.
Thank you so much.
Thank you.
And don't forget to
All
email
right.
if you want to do a presentation for the next mentoring session.
Yeah, 2 weeks from now, we'd love to have one of you or two of you make a case presentation, and we can work with you to find the case. You don't have to come up with the case. One of the other mentors can help you get that up to speed.
Mhm.
I
All
want
right.
to do one. Yeah.
Okay. Great.
Great.
We'll connect you with Dr. Prokocha and let you work with him on a case presentation.
Thank
All
you,
right.
Dr. Hassel. I learned a lot.
I did too.
Thanks. Thanks, everybody.
Bye.